We will explain today an important article talking about urogynecological problems in pregnancy. This talk article addresses mainly some important issues like stress incontinence with pregnancy, overactive bladder with pregnancy, genital prolapse in pregnancy and postpartum, and urinary problems like voiding dysfunction in pregnancy and after delivery. First one is talking about stress urinary incontinence. And it's the first because it's the most common type of incontinence in pregnancy. And it's a very common problem and can affect even up to 75% of pregnant women may suffer from stress incontinence. With increasing gestational age, the problem increases gradually. There are many risk factors. Pregnancy itself is a risk factor. Also, weakness of the pelvic floor muscles, being pregnancy, as we said, and obesity is another risk factor, smoking and constipation. And from them, we can know what can be the conservative lines of management: pelvic floor muscle training, reducing body weight, avoiding smoking, avoiding constipations, treating any cause for cuff or Valsalva maneuver. Vaginal delivery itself is also a risk factor. So women who deliver vaginally, the risk is 8% more than women who deliver by cesarean section. A study was done about the delivery in multiple pregnancy. They found that cesarean section was associated with less risk of stress incontinence in comparison to vaginal delivery. And most of women who have stress incontinence before the pregnancy, they will suffer from incontinence during the pregnancy. But if the woman didn't have any incontinence before the pregnancy, she has less risk of developing stress incontinence during pregnancy. So talking about 73% versus 13% if the patient didn't have incontinence before the pregnancy. During the pregnancy, our treatment will be mainly conservative, like pelvic floor muscle training. It can improve the symptoms. Even in the long term, it can do improvement. So we don't offer surgery except after the patient completes her family, because next pregnancy and deliveries can compromise the success of the operation. That's why it can be offered after completing the family first. So this was the first problem about stress incontinence in pregnancy. The second urogyny problem in pregnancy is overactive bladder. It's also something very common in the form of frequency of micturition, which is the most common symptom of overactive bladder in pregnancy. Also, bladder capacity is reduced in the third trimester about 100 milliliter less than its capacity in the first trimester. Another symptom is having urinary urgency. It's also very common, up to 31%. The treatment of overactive bladder symptoms in pregnancy, as we said, manifestations are in the form of frequency, urgency, reduced capacity. The treatment number one, conservative. 2, modify fluid intake, avoid or reduce caffeine, pelvic floor training, and bladder training. Medications like antimuscarinics can be prescribed in pregnancy, like oxybutynin. You know, usually we start with oxybutynin because it's the cheapest anticholinergic anti-M3. Intravaginal estrogen, if given in low dose, it can improve the manifestations, because you know estrogen is important for healthy urethra and healthy urinary mucosa. Botox injection, it's not commonly offered, and the evidence say it can be safe in pregnancy. Okay, but so far it's not commonly offered in pregnancy. And if we prescribe it, take care, there is a risk of urine retention. That's why the patient should be trained to have intermittent self-castration. The other lines of treatment which are considered surgical, like sacral nerve modulation and tibial nerve stimulation. Tibial nerve, we don't have evidence. Sacral nerve, it should be not used in pregnancy. Even if it was applied already pre-pregnancy, it should be turned off because we don't have enough evidence about its safety so far. The current evidence showing no anomalies, but we are not, we don't have enough evidence about its safety. That's why if it's present, if it's applied, it should be turned off. Of course, after we turn it off, symptoms will have relapse. But so far, the evidence is not to continue using sacral nerve modulation during pregnancy. All manifestations of overactive bladder mostly will improve within 6 weeks after delivery. Sometimes may fluctuate. If persistent or progressing more, we should consult urogyny. So this was second problem, which is overactive bladder in pregnancy. The third urogyny problem in this talk article is pelvic organ prolapse. It's one of the common problems complicating pregnancies and deliveries, more with even vaginal deliveries than cesarean sections. They found that with increasing gestational age, the prognosis is deteriorating more, and the worst, so the highest BOPQ stage is around 36 up to 6 weeks after delivery. It can come as a question. So from 36 weeks up to 6 weeks postnatal. And there are some changes which will happen to all women during delivery, but to reach to the degree of being a significant tear, this affects only some women. There are many risk factors for having BOP after pregnancy and delivery. Pregnancy and delivery are risk factors. Difficult delivery, instrumental delivery, prolonged second stage of labor, large baby, third and fourth degree perineal tear, even if the head is extended, it can do trauma to the pelvic muscles. More specific when we talk about puborectalis muscle, which is part from the levator ani, which is present here. It's around the rectum and the vagina. Okay, it can have a tear during delivery, and this can lead to pelvic organ prolapse. And even levator ani as a whole, it can have a tear or avulsion. This avulsion will lead to cystocele and uterine prolapse. So generally, levator ani damage, more important puborectalis, can predispose to pelvic organ prolapse. Okay, how we can manage pelvic organ prolapse during pregnancy? We will not go to surgery. So conservative management. Okay, like reducing intra-abdominal pressure with treating constipation with laxative, treating a cough with cessation of smoking and anti-cough preparations, and avoiding lifting heavy objects. Diet and exercise to control the overweight and obesity problems, training pelvic floor muscles, it can prevent long-term prolapse using pessaries if prolapse is affecting the quality of life, and we will not do surgery during the pregnancy. We will delay it to when the patient completes. The next urogyny problem in this talk article is recurrent UTI. What is the meaning of recurrent UTI? It means having 3 attacks of UTI within 1 year or 2 attacks within 6 months, provided that the patient showed culture positive and as long as it's UTI, so there are symptoms. The most important risk factor for recurrent UTI, whatever the patient is pregnant or not, is having asymptomatic bacteriuria. What is the meaning of asymptomatic bacteriuria? It's having urine culture showing growth of more than or equal 100,000 colony forming units per milliliter, provided that the patient is not symptomatic, otherwise, it's going to be considered infection, not just asymptomatic bacteriuria. About 2 to 7% of pregnant women they have asymptomatic bacteriuria. Similar number in non-pregnant, 6 to 7%. So, do we need to screen during pregnancy? Of course, it's routine in antenatal clinic in UK to screen for asymptomatic bacteriuria at booking visit. Why? Because if asymptomatic bacteriuria is not treated, the risk of UTI will increase up to 25%. which is a very big number. Normally, UTI number is 8%, but if we didn't detect and treat asymptomatic bacteriuria, the risk will increase to become 25%. That's why we screen for it. How we screen? By doing midstream urine culture at booking visits. What if it's not treated? As we said, the risk of UTI will become 25%. Okay, what is the general risk of UTI in pregnancy? 8% of pregnant women they have UTI. 2% can develop pyelonephritis. UTI can lead to serious complications like preterm birth, stillbirth, chorioamnionitis, and small for gestational age. If you suspect infection, first thing you will do is urine dipstick for nitrite. Is it very accurate? The answer it's partially accurate if you are talking about gram-negative bacteria, because gram-negative bacteria can lead to reduction of nitrate to nitrite. Unfortunately, gram-positive bacteria does not do the same. That's why if the patient is symptomatic and nitrite test is negative, please do urine culture because the cause can be a gram-positive bacteria which does not reduce nitrate to nitrite. We said what is the meaning of recurrent? 3 attacks per year or 2 attacks in 6 months. Okay. Why postpartum women are susceptible for UTI? During postpartum, especially if the patient is lactating with increased prolactin level, the level of estrogen will be reduced. That's why the epithelium will be weak, susceptible for infection. Other risk factors for recurrent UTI: early UTI at age less than 15, maternal family history of UTI, frequent intercourse, that's why we can do prophylaxis to this point, multiple multiparity, so repeated trauma, so infection, low socioeconomic level, so poor hygiene, hydronephrosis, and renal stones, which can affect urine flow, so again, recurrent UTI. There was a Cochrane done comparing two groups. One group receiving just surveillance, follow-ups, doing dipstick test, okay, and the other group also close surveillance plus receiving prophylactic daily nitrofurantoin. So one doing only surveillance, another one surveillance plus daily prophylactic nitrofurantoin. Both groups showed same result in relation to showed same result in recurrent UTI. But the advantage in the nitrofurantoin group that asymptomatic bacteriuria was less, but recurrent UTI was the same. Okay, what prophylaxis can be given for recurrent UTI? And is there difference in pregnant versus non-pregnant? We can do the same, whatever pregnant or not. Like taking every night trimethoprim, but take care in pregnancy, it's not to be given in first trimester. Or giving every night nitrofurantoin, but take care not to be given in the third trimester. Or amoxicillin. So here we have 3 possible antibiotics as prophylaxis. Okay. After treating UTI, it's practically not by guidelines recommended to do repeat urine culture. And if you are giving the antibiotic for a patient with recurrent UTI, serial testing will be needed twice weekly until 36 weeks and then every week to detect any recurrence of the UTI. Okay, women with recurrent UTI, can we do prophylaxis in pregnancy? Yes. Hygiene by offering douching and washing, not douching, washing and just avoiding after intercourse, and cleaning and washing the genital area, it's protective. Vitamin C, protective. Canefron, okay, it's antibacterial probability medication and it's safe in pregnancy, but we don't have enough studies. But so far, it's safe. Another one, methenamine, which also helps to protect because it can give a product called formaldehyde. This formaldehyde has antiseptic properties. Another one called demon nose, which is proved to be safe in pregnancy. This demon nose, it acts by helps the bacteria to move through the urine stream. It prevents the bacteria of being sticky to the epithelium or the mucosa, so it will be discharged with urine without leading infection. So demon nose is considered safe, vitamin C considered safe, hygiene of course considered safe. So with these methods, we can reduce the risk of recurrent UTI. The next urogyny problem is urine retention in pregnancy, and here we talk more about RVF uterus. Most of women with RVF uterus, which is present already in 20% of women, it will improve during second trimester. The problem if the uterus became fixed RVF, okay, mainly because of adhesions or abnormality, or if sacral promontory itself is deep. This will incarcerate the uterus inside the pelvic cavity, preventing its spontaneous correction. In this situation, the cervix will be pushing against the urethra, which can lead to urine retention. So, if this problem, which may happen at around 14 to 18 weeks of pregnancy, if didn't improve spontaneously, correction under anesthesia may be needed. Another problem can lead to urine retention in pregnancy is during the delivery itself. So, during delivery, encourage repeated bladder evacuation. Otherwise, if the bladder is not evacuated well, trauma to the bladder and trouser muscle will happen, leading to its damage. Later, this will lead to voiding problems, the trouser underactivity because multiple trauma, frequency of micturition, or nocturia. That's why, please, if the patient is receiving epidural, apply indwelling caster. During cesarean section, apply indwelling caster before starting cesarean section. And during the follow-up, encourage fluid balance to avoid dehydration. And ensure good fluid intake always. Ask the patient after removal of the caster to void every 3 hours. If the patient didn't void well, here there can be a problem if she didn't void within 6 hours after removal of the caster. Here I may do recasterization again and I can assess the bladder volume using ultrasound. So, postpartum urine retention can affect from 15 up to 25% of women after delivery, and it will be more towards 25 if the delivery was vaginal delivery. It has two types, either overt, that the patient cannot void at all within 6 hours after delivery, or after removal of the catheter after cesarean section, or covert, that she can evacuate but there is much amount of residual urine which is more than 150 milliliter or 150 milliliter. When we find this, okay, we have to apply ultrasound to measure the amount of post void residual urine, or applying even a catheter to assess how much residual urine is present. Risk factors for postpartum urine retention: epidural, that's why during epidural keep the caster in situ; prolonged first and second stage of labor; instrumental delivery; episiotomy; primiparous; and the physiological change itself, like increased level of progesterone. If we suspect that there is urine retention, correct any pain, so give good analgesia. If there is constipation, you can treat it. Ask the patient to walk around. This can help urine voiding to occur normally. If not helpful, we can apply a castration to assess how much residual urine is present. Ultrasound actually is better here because it's non-invasive method. If we treat postpartum urine retention in a good way, usually there will be no long-term complications. Although some complications may happen, like long-term urinary symptoms. Another problem may happen with this urine retention if it's painless. For example, if the patient receiving epidural, she can have painless urine retention. Unfortunately, it can do damage to the bladder and the detrusor muscle, and it can lead to the need for lifelong castration because of long-term voiding. Here we have one of the algorithms about how to diagnose and manage postpartum urine voiding problems. We have to ask the patient to void within 4 maximum 6 hours. After caster removal, we should ask her to void. There are two possibilities. The patient could void or not. If the patient could not void at all, I should evacuate the bladder because I removed the caster in 6 hours and she didn't void. Using the caster, I will assess how much urine was present inside. If the amount very small, less than 150, I will check if the patient is hydrated good or not. If the amount 150 or more, so there was urine retention. If the amount very large, more than 700 milliliter, keep the caster inside and the patient will come again after 2 weeks to remove the caster and assess the post voiding problems and the post voiding urine residual. If the amount small, 150 to 250, we can try and ask her again to void after 6 hours. If the amount borderline 250 to 700, insert a catheter and within 24 hours remove the catheter again and ask the patient to try to void without catheter. TWOC means try to void without a catheter. What if the patient on the opposite side she could void? Okay, not all voiding is the same. We need to ask the urine volume was good, you feel satisfied, you emptied your bladder, any sensation that you want to enter the toilet again? Okay, what about the stream and do you feel any incontinence or not? If the patient has problems in this VISI questionnaire, if there are problems, we will apply a caster to see how much urine is present inside. If the amount more than 700, keep the caster 2 weeks. If the amount less than 250, proceed again and try again within 6 hours to ask the patient to void. If the amount 250 to 700, try again without caster to ask the patient to void within 24 hours. As you see, the three options here same like the three options there, but the difference the cutoff level. Here 150 to 150, 250 70, more than 700, and here less than 250, 250 700, and more than 700. If this questionnaire showed that there is no any problem, okay, congratulations. But please try again within 6 hours to find if there is any problem. This is one of the suggested protocols to assess the postpartum voiding. And this was the end of this very important article talking about urogyn problems in pregnancy and postpartum.